Hello, my name is Giovanni Guaraldi, and thank you for allowing me to present this study on behalf of my co-author. The title is Cognitive Frailty in People Living with HIV and its Association with Geriatric Syndrome. These are my disclosure. Let me get into the background to stress the fact that we want to move from the hand construct. In fact, we know that the significance of low cognitive test performance without symptom is uncertain. And there is really the idea of proposing a new framework in which, in fact, a symptomatic cognitive impairment from any cause in people living with HIV should be more aligned with the clinical observation and more closely represent HIV pathology. Interesting, these conditions are often associated with comorbidities, but while in the hand existing criteria, these were defined as confounding or contributing to hand, actually in this new framework, comorbidity factors should be specified along the relative contribution of HIV brain disease. This is not new because, in fact, we know that, for instance, in previous study in Alzheimer's dementia, frailty rather than single comorbidity profoundly influences disease expression. We know that individuals with marked Alzheimer's disease pathology may not meet the criteria for dementia if they are fit with low level of frailty, while those with modest neuropathological burden are at increased risk for dementia if they have high degree of frailty. And for this reason, the International Association of Gerontology and Geriatrics and the International Academy of Nutrition and Aging built this new cognitive frailty construct. These are heterogeneous clinical manifestations that are characterized by the simultaneous presence of physical frailty and major cognitive impairment with the exclusion of Alzheimer's dementia. Actually, the importance of this construct is not rather to be considered as a pre-dementia syndrome, but the possibility to identify cognitive frailty as a reversible condition that is also supported by the assessment of biomarkers like, for instance, amyloid or neurotide as neurological damage biomarkers. And with regard to the frailty contribution, we know that its component, that is the physical and cognitive component, should be considered as separate entity rather than a part of a single macrophenotype. The importance of cognitive frailty is that we know at a clinical level that it is associated with adverse outcome, like, for instance, falls or disability, but even more the idea that clinical frailty may be a novel target for the prevention of elderly dependence. As far as we are concerned, no one ever described cognitive frailty in people living with HIV. We wanted to determine its prevalence, but also the risk factor for this condition and its association with geriatric syndrome, like, for instance, polypharmacy or physical status evaluated with short physical performance battery. This was an observational cross-sectional study that included people that from 2016 in the very same visit were assessed with frailty using a 37-item frailty index, and we use a cutoff of more than 0.3 to define frailty, and with an assessment of cognitive impairment through COG state. The clinical outcome measure of the study were polypharmacy, defined as 5 or more drugs above antiretroviral therapy, and physical performance battery. The COG state battery assess the simple speed processing, the complex speed processing, the attention and working memory, the visual learning memory, the verbal learning, and the verbal memory. The cog state actually return for each of these domains a raw zeta score. We defined a domain as a deficit if the raw zeta score is minus of -1, and the mean deficit score of the 6 domains, that actually the number of deficit above 6 was used to define a GDS, a global score, that was impaired if more or equal than 0.5. With regard of the result, we were able to assess 3,091 individual. You can see that the people with cognitive impairment on the left side have a lower score for each of the 6 cognitive domain. And with regard of the contemporary presence of cognitive impairment with frailty, this was identified in 91 individuals, that is the 6.5% of the population. With regard of demographic, HIV, and clinical variable, you can recognize that people with cognitive frailty were somehow older and had a higher BMI. With regard of HIV variable, you can recognize that they had lower nadir CD4 cell count, but also lower current CD4 cell count, but more interesting also lower CD4-CD8 ratio. The number of years since HIV diagnosis was higher, and interesting, the cumulative exposure to dolutegravir appeared to be higher. Actually, we examined all antiretroviral exposure, and this was the only signal that was associated with these drugs. Polypharmacy was higher in people with cognitive frailty compared to all the other individuals. Very interestingly, we also identified that people with cognitive frailty had a higher level of CRP and D-dimer. With regard of the multivariable logistic regression analysis, the predictor of cognitive frailty was not just age, but also the time since HIV diagnosis and polypharmacy. If ever we tried to assess polypharmacy as an outcome, we confirm that not just age, but also cognitive frailty was a predictor of this geriatric syndrome. And with regard of the predictor of physical function per each SPPP point decrease, cognitive frailty, polypharmacy, and age resulted to be independent predictors. And so we may conclude that cognitive frailty prevalence in people living with HIV age more than 50 years was higher, and to the same proportion of people above the age of 65 in the general population. And the time since HIV diagnosis predicted cognitive frailty, suggesting an HIV specificity associated with an increased inflammatory status. With regard to the signal that we observed in the description analysis, with higher exposure of cumulative exposure to dolutegravir, this was not confirmed in the multivariable analysis, and presumably this is, let us say, a proxy of older age, or rather the preference of using dolutegravir in people who are frailer or more vulnerable with regard of comorbidity present. And the strong association between cognitive frailty and the trajectory of physical function decay suggests that physical function may represent a rehabilitation intervention to revert both frailty and cognitive impairment. Thank you so much for your attention.
Yeah.